خلينا أديك نقدم كده. طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. Welcome in this series, in this webinar. This is our third lecture with Dr. Sara AlQatari. Dr. Sara, she's a physical medicine and rehabilitation consultant in King Fahad Medical City. She got her fellowship in musculoskeletal rehabilitation from McMaster University in Canada. Welcome, Dr. Sara, and thank you for accepting our invitation.
Thank you, Dr. Mohammed, and thank you everybody for attending. It's my pleasure to present to you today. So today I will talk about, because the topic is about tips of clinical practice. So I thought that I will talk about what I'm doing in the clinic as MSK clinic. And how do we approach our MSK patients? So this is the general approach for an MSK patient. Our approach is called patient-centered approach. That means the patient should be he should share, and he should make decisions with us after assessing the patient. I will go fast through this, and then we can discuss another case presentation and how to apply the approach on the case. So whenever a patient comes to our clinic, we have to give them the space to talk and to ventilate and to express why they are presenting to our clinic and what's the chief complaint, and talk about it without interrupting the patient. If we want to ask, we can give the patient open-ended questions and let them talk. And while they're talking, we can set up our goals, which is if we are working in a rehab clinic, that means our goals should be functional goals. After that, we can make a decision about the management plan together with the patient after explaining everything to the patient. Also in MSK clinic, always put in your mind that history comes first over any other investigations. We need to take detailed history about the chief complaint. The most common chief complaint, like more than maybe 98% of our patients, they present with pain. Whatever pain in the back, pain in any joint, chronic, acute, subacute pain, any type of pain. So we have to take full details history about the pain, and we have to pay attention for the red flags. Who can tell me some of the red flags that you need to pay attention in the clinic? Anyone?
ممكن pain at night.
Yes. Night pain, that's right. Anything else that comes to your mind? Okay, so red flags.
History of
Yes.
trauma, history of traumas, history of
Yes.
significant weight loss within 1 month or 2 months. That's it.
Yes, excellent. History of trauma, history of fracture, significant weight loss, night pain, night sweating, swelling, signs of an inflammation, signs of infection, redness. All of this should be taken seriously during the assessment of the patient. And functional assessment, what do we mean by functional assessment? We need to assess function of the patient, like If the complaint is affecting his function, like walking, running, if he's in sport, if it's affecting the sport that he's doing, or it's secondary also to sport that he's doing, and also the daily activities, functional daily activities, if the patient is working, if it's affecting his work or no. And
There
then
are some
exam.
comments in the chat.
Yes,
They wrote
yes.
ADL and GATE.
Oh, yeah. Let me see. Excellent. ADL and GATE is something that we need always to assess in our patients in any rehab clinic. Okay. So an examination, we need to do, all of us, we know how to do MSK examination by first inspection, look, feel, move, and test. And always don't forget to examine the other side, because many of the times when a patient come with a complaint unilateral, sometimes we forget to examine the other side. And it's very important because it gives you like a hint about the diagnosis. Also, we need to differentiate always about the pain. What type of pains that we have that we need to think about. Yes. Excellent. Nociceptive neuropathic pain, mixed, sharp, dull. This is how to, what's the character of the pain? Is it sharp? Is it dull, stabbing pain? This is the character of the pain, and there's types of pain. Like, is it nociceptive pain or neuropathic pain? Is it mechanical or inflammatory or mix? Okay. And before doing any special tests, we need to know what's the sensitivity and specificity of the special test. For example, in a patient coming with a shoulder pain or hip pain, we know all the special tests, but if we don't know the sensitivity and specificity, we will be lost when we're examining our patient. Because we need to know what exactly where exactly the pain will be. Sometimes you examine the shoulder and the patient will say yes, it's painful, but when you dig in that, he will point to somewhere else other than the area that you're testing. In this case, you cannot say it's a positive test. Always use simple language when talking to patients. Always take good notes. Always try to explain to your patients. Many of our patients, when they arrive, they don't have clear explanation about what's going on. The pain for them is vague. They don't know what's the cause behind it. And when you explain to them, they will appreciate, really, they will appreciate, because now they understand what's the pathophysiology and what they can expect about their prognosis, about their pain. So it's really good to explain to the patients. Use any model around you and talk to them. طبعا we need to use evidence-based management plans and follow guidelines. Because also we're covering rehab clinic, we need always to do interdisciplinary collaboration with our allied health colleagues, other physicians from different specialties. We have to enroll them in our management plan. And okay. So this is the case that I will be talking about, case of osteoarthritis. And I chose osteoarthritis, especially knee, because it's the most common presentation in my, or one of the most common presentations in my clinic. So you have that 68-year-old female who presented with knee pain, and she has that morning stiffness that lasts more than 20 minutes. You examined the patient, you found a crepitus and decreased in range of motion, and it's diagnosed by X-ray that she has osteoarthritis, joint space narrowing, and osteophytes. So what's the management protocol? I will jump immediately to the management. We want to focus on the management options for such a case. And it's not only for the knee, but we will focus on the knee today. Who can tell me what's the management that you can think about in such cases? Medical and non-medical. Yes, you mean pharmacological and non-pharmacological. طيب, what do you think is more important or superior than the other? Exactly. Yes. Yes, exactly. The non-pharmacological is way superior than the pharmacological management in such case. Lifestyle modification, weight reduction, be active, don't be passive. Physical therapy, that's right. Yes. We have to keep mobilizing and not be just passive. Weight reduction, aerobic exercise, swimming, and orthosis. That's right. Swimming and aerobic exercise is very, very, very helpful. It's maybe number one it's on the top of the management plan for such cases. And weight reduction, yes. So the non-pharmacological, as we mentioned, and then we can use physical modalities, pharmacological, intra-articular injections, and lastly, surgical options. طيب. Non-pharmacological is lifestyle modifications and exercise, then physical modalities, pharmacology, injections, and lastly, surgery. Non-pharmacological, as you mentioned. Okay. Patient education, weight reduction, exercise, aerobic, and strengthening for quadriceps muscles, especially in knee osteoarthritis. Using braces and walking aids. And let's talk about the pharmacological management now. What type of pharmacological management you will prescribe for such cases? Yes. Paracetamol, non-steroidal. Yes, start with topical. We always start with topical. Topical non-steroidal is excellent, and it gives good results, and it has less side effects. Doesn't have that much of systemic side effects for medications. طيب دكتور فاطمة, paracetamol and non-steroidal. Which one do you think is better? Non-steroidal. Non-steroidal is much better to treat such cases than paracetamol. Paracetamol have less it's less effective. Gel or patch, what is better? Wallahi, both. Some patients they do very well with gel. I like to start with gel, to be honest. And then if not working, not effective, I can use patches. Some patients had good results with gel, and because the gel you can use it for like small areas anywhere. I like it for small joints because they can control it very well. For example, hand joints of the hand, shoulder, elbow, I think the gel is better. I always use patches for back pain, for example, because you need to cover a larger area and it's hard to apply the gel for the back. Yes, the gel so I prefer patches for back pain and sometimes for knee pain. But for small joints, I prefer gel. So as we mentioned, paracetamol, non-steroidal, topical, and finally also duloxetine. There is an evidence that duloxetine could give good results, especially in chronic pain. That's not responding to, or you cannot, because paracetamol and non-steroidal also you cannot use it for a long time. So what we do usually, we give a short period of non-steroidal and with PRN paracetamol, but after that you cannot let the patient continue on such medications because of their side effects. So duloxetine is a good option also. طيب, let's move to the intra-articular injections. What types of intra-articular injections? طبعا intra-articular injections comes after the oral or topical, then oral, and then we can move to the injections. So what type of injections that we know? Yes. Hyaluronic acid injection and steroids. These are the most common types of injections. But steroid, PRP. PRP injections is now evolved. A lot of studies there's a lot of study about using PRP in managing such pain. Okay, so as you mentioned, corticosteroids injection and hyaluronic acid and PRP. It's an emerging evidence, as we said, but many people that tried PRP, they reported good improvement. طيب, what will you prefer in the clinic and why? Steroid, why is that? Excellent, it gives fast improvement. Yes, yes. So in Dr. Iman, in flare of arthritis or not, what will you use in the flare of arthritis? What's better to use in flare of arthritis? Yes, exactly. You will use a steroid because steroid will give fast effect. And if the patient's really, really in pain, you can also mix a steroid with anesthetic. So it will, the anesthetic will be diagnostic, immediate diagnosis. And then you can, the steroid will give fast and the quick effect. Dr. Hamza, I agree with you that PRP has less side effects. It's safe option, but it's emerging evidence. That's the problem with PRP. I agree with Dr. Nora. Steroid is the evidence-based supported mode of intra-articular injection. That's why most of the time we use corticosteroid to treat osteoarthritic pain. طيب when do we use hyaluronic acid? A lot of residents in the clinic, they ask me this question, and when do we use hyaluronic acid? When do we prefer hyaluronic acid than corticosteroid? Both are, yes, when there is morning stiffness. Yes, in younger patients, that's right. In mild to moderate arthritis, that's right. Dr. Riyadh, what do you mean by chronic use? Okay, yes, most of you know the right answer, or at least guessed. So, hyaluronic acid is preferred. There's a okay. Chronic kidney disease. You are right. Like for me, I don't like to inject corticosteroid in patients with like multiple medical comorbidities. I don't prefer, although there is no clear contraindication for corticosteroid injection, because even intra-articular is not considered as a systemic treatment. But you can, if you're not comfortable, you can offer hyaluronic acid because it's safer, has less side effects. But yes, in advanced osteoarthritis, it will not, most likely it will not help. It helps in early stages and in younger patients. So mild to moderate knee osteoarthritis, grade 2-3, patient who cannot tolerate non-steroidal anti-inflammatory drugs or steroid injection, patient not responding adequately to first-line therapy, and who don't want, this is right, steroid-sparing option. I think it's explaining what Dr. Riyadh said. They want to spare the steroid using until later on time, for example. If patient is under oral anticoagulant, this is a very good question. Thank you for asking this, because it's really important to mention. I forget to mention it. It's really important. We have to make sure that the patient is not under oral anticoagulant, and we have to instruct the patient, if he's on anticoagulant, to stop the anticoagulant before presenting to our clinic, to avoid hemorrhage. Younger and active patients. Sometimes also we combine the management. Hyaluronic acid can be given in combination with corticosteroid. And who knows why or when do we combine them? Or why? What's the benefit of combining them? To get rapid relief, this is right, and longer effect, this is right also. So you need to both, if there is chronic pain. Usually we combine them. Both answers are right. You combine them when you have a flare and you want immediate relief. The steroid will give a good relief at the beginning, but in most cases, the steroid will give short-term effect, 4 to 6 weeks maximum. Not in all patients, but some of the patients, they have just short-term relief. In these cases, maybe if you combine the hyaluronic acid together with the corticosteroid, you will have a longer duration because the effect of hyaluronic acid will appear later on time. So you can cover immediate relief, and then also you will help the patient after that by the hyaluronic acid. Dr. Mohammed, I see your question, but if you allow me, we can go back to this question at the end, if you don't mind. طيب, when we are talking about patients who received all the oral painkillers, who received injections, they're not improving, the pain is not going away. They're still complaining, but they're yet not good candidates for surgery. What do we do in these cases? Yes, but let's say the patient has a severe pain that's intolerable, that even make them cannot tolerate physiotherapy sessions. Or what if they already tried physical therapy, physical modalities, and nothing worked with them? Nerve ablation and nerve block. That's the right answer. What's genicular nerve block? Yes, this is the name of the nerve that we will block. And what's the difference between the ablation and nerve block?
I think block is diagnostic while ablation is more therapeutic.
Yes, exactly. Ablation, nerve block to diagnose, to see if there is a good effect with the block, then you can send the patient for nerve ablation. Usually we refer our patient to pain clinic to receive the genicular nerve ablation. This is here are the areas, superomedial genicular nerve, superolateral and inferomedial. We start with nerve block, and if there is good response with nerve block, we can recommend nerve ablation for the patient. It's very good, like it gives good relief, and like you can do it for patients before sending them for surgery. أو يعني in our cases, in our practice, they fit for surgery, but you know the waiting list for surgery takes 1 year or more sometimes. So meanwhile, you can proceed with the genicular nerve, and then go for surgery after that. طيب, physical modalities. طبعا physical modalities is non-pharmacological management. We can يعني maybe it's better to put them after the non-pharm or together with the non-pharmacological management. But anybody know some of the physical modalities that's recommended in such cases? Yes, it will help when you improve sometimes in many. I will answer this question. It will treat pain, but how about patient function? Yes, it will help patient function by relieving the pain. When the pain is relieved, the patient could do better exercise, could do good strengthening for the muscles, especially quadriceps muscles, and then that will improve the function as well. So indirect improving of the function. Cryotherapy, TENS, laser therapy, ultrasound, hot packs, and TENS. Yes, all of them are right. In knee osteoarthritis, what do you think could be better than other? All of them are right, actually. Okay. So thermotherapy, heat, cold, it's very good to improve the stiffness and pain. Low level light therapy, this is I think the best. It has a highest efficacy for pain reduction and improving function. TENS also is very good. It's like I'm not sure if the TENS and the low level light therapy are equal, or it's written here it's second for pain, but it's really commonly used and very good. Shock waves, also very good. Ultrasound therapy is used, but it's not it doesn't give good relief for that pain. Okay. And then lastly, after that,
Doctor, I
yes.
have a question regarding steroid injection. If the patient, when's the last time to give injection before? If the patient planned for a surgery and there is a long list,
Yes.
is it possible to give him steroid injection, or not to delay, or duration between steroid injection and surgical intervention acceptable?
Well, the way that I'm doing it is if there is more than 6 months space, I give steroid injection. If it's 6 months or less, I don't give steroid injection. This is how I do it. ما أدري إذا دكتور محمد جميل have another answer for that.
Well, doctor, usually we wait for at least 3 months. I agree with you, 6 months is a safe period. But anything more than 3 months, it should be safe.
Yes.
So if your patient will have his surgery in the period less than 3 months, it's better to avoid injection.
I see in the chat, Dr. Iman, you are right. Ultrasound is good for localizing causes, insulin bursitis or tendinopathies. That when a patient presents to your clinic with knee pain, and you want to diagnose the pain, it's very good idea to screen with the ultrasound, even if you have an established diagnosis of osteoarthritis. The patient can present with already diagnosed with knee osteoarthritis, and sometimes they send the patient for intervention immediately. But when you do the ultrasound or send the patient for ultrasound, you will figure out that the patient has insulin bursitis. And it's actually the source of the pain. And sometimes both the knee osteoarthritis and insulin bursitis. It's really common. And I know a lot of doctors, even if the patient didn't complain, I don't do it. I do it only if I'm sure there is insulin bursitis. But I know some doctors who will inject the insulin bursitis together with the knee osteoarthritis. Okay. Surgical options. Total knee replacement, this is the most common. This is what we always see because most of our patients who present to our clinic are with advanced OA and elderly. So this is the most common type of surgery. But there is also the osteotomy. If you know about it, it's or sometimes it's done with athletes, younger patients. Different surgical approach. بس يعني these both of them are surgical solutions. And that's all for now. I don't know if we are open for discussion if you want to ask anything. Dr. Muhammad, I will answer your question that you asked earlier about the oral management. Or actually, we don't use oral steroids in managing acute pain or osteoarthritic pain. We use non-steroidal. It gives a very good results and good relief for the pain. I don't use steroid. Maybe steroids, it's better to be given in inflammatory or rheumatological cases. And صراحة يعني I leave it for rheumatologist. I don't give steroid. Glucosamine, I see a lot of patients who came, they are already taking glucosamine and they're happy with it. I don't also prescribe it. It's not evidence-based, but I tell them if you're happy with it and you feel comfortable taking it, you can take it. I don't prescribe it. Dr. Hoor, I see your question. It's nice. Wallah, strengthening is the best in such cases. Applying knee brace also is excellent. I think these are the golden standard management for such patients because you're focusing on the function here and you don't want to treat the pain. Maybe you can try the hyaluronic acid injection in this case. Maybe it will give also good result, effective.
يعطيك العافية دكتورة.
الله يعافيك دكتور.
What about the decision for severe osteoarthritis? The first presentation for in our clinic, decision between injection steroid or genicular nerve block with using steroid, so it will give a long effect of pain relief.
Yes.
Decision between steroid versus genicular nerve block.
Usually I start with the steroid injection. You can give both of them also. There is no contraindication. But when you give a patient repeatedly steroid injection and then you want to try something else that could be more effective, and also it could you can spare some space between giving two steroid injection. In this case, you can like combine the management. You can give corticosteroid and then give a follow-up for genicular nerve block, and then you can continue giving the steroid injection, but you will increase the space between the injection, which is a good, I think, idea. It's always there is no like fixed something like fixed in managing your patients. You have the clinical sense to judge. It's different from one patient to another. And Dr. Iman, you mentioned about the correlation between radiological finding and patient symptoms. It's not always, you are right, not always correlated. There is a correlation, but not always. Sometimes severe osteoarthritis, but less pain. I don't think naproxen has superior effect than any other type of non-steroidal anti-inflammatory drugs. Any other question? Anything you want to discuss? Is going. Collagen supplement, it will not relieve the symptoms, but it might give, it's not evidence-based, collagen supplements, but it might give like, you can delay or postpone the progression of developing more like degenerative changes in the joint. But if the patient has pain, it will not improve the pain. I see patients after TKR and they are still have persistent pain. Well, I go back to the beginning. I start again from non-pharmacological, and I focus on non-pharmacological in such cases because here really you need to educate the patient. And then if still have pain, you can give pharmacological like oral, but yani, of course you will not think about injections at all. It's contraindication in such cases. Dr. Samah, thank you for that information. I don't use it, but it's good to see also other like I see your point of view, and we can also consider it as a management in our patient. What is the most safest non-steroidal? I like Celebrex. I think Celebrex is the most safest. Yes, COX-2 inhibitors. You're welcome. Thanks to you all. You're welcome, Dr. Iman. Thank you so much. You're welcome. بالتوفيق للR4. I want to give you small advice before your coming exams also. Believe in yourself and be confident and go systematic, and you will do great. And focus on MSK clinical examination, because for sure your exam will have you will have stations of clinical physical examination. So focus on them and try to be calm as much as possible. Take your time, but try to manage your time as well.
يعطيك العافية دكتورة سارة.
Allah يعافيك Dr. Abdullah. Thank you so much.
Thank you for your time presentation. This was really good one.
Welcome.
So if no one has a question, then we can end the meeting here. Thank you all for your attendance.
Thank you.
I think there is one more question.
Okay.
Um,
Um,
for advanced osteoarthritis, would we use nerve ablation, or do we go directly with total knee replacement?
Okay, so in advanced osteoarthritis, nerve ablation is more like it's safer than total knee replacement. It's a non-surgical option. It gives good results, and you can start with the ablation, and then still you can put the total knee replacement in a plan. Sometimes you have a younger patient that you don't want to, or they're not a good candidate for total knee replacement, for example, but they have advanced osteoarthritis. Or even, as I said, maybe long list for their surgery. Or maybe the patient themselves, they don't prefer to go for surgery, or maybe they're afraid of a lot of things. يعني the surgical option is always the last option. Nerve ablation is safer, and it can يعني help the patient without surgical intervention. You're welcome. Any other question?
Thank you, everyone, and we'll see you, inshallah. We'll meet again tomorrow for the next upcoming series. Have a nice day.